to our final transfusion bite of the day, and this is given by Sally Gleave. Sally is an assistant transfusion practitioner at St Richard's in Chichester, and she's relatively new to the role, but she's joined from another NHS trust in 2022. She's a registered nurse with background experience in emergency hospital assessment. Her presentation is entitled Eisenmenger syndrome and blood transfusion. Sally, would you like to take it away, please?
Yeah, well, thank you very much for this opportunity to share this very exciting case that we had here at St Richard's Hospital in Chichester. It's about a patient who came with Eisenmenger syndrome. We'd never heard of it, and they needed a blood transfusion. So I really hope that you find this really interesting and that you can all learn a little bit about it. Next slide, please. So basically, I was sat in my office here at St Richard's, and the BMS came through to me in a bit of a panic with a request form in hand, 2 units of red blood cells requested for a patient on our emergency floor. Patient's HB was 166, no active bleeding. Of course, the BMS was very reluctant to issue this blood. What's this about? Okay, this is very strange. So I said, calm down, it's okay, I'll go and find out what's happening. So off I popped down to emergency floor. Thank you. So I went down there and they were all a bit shocked to see me, I think. But the consultant was around and I said, could I go and have a chat with him? So while I waited for him to come speak to me, I had a little nosy at this patient's notes. The lady was admitted via ambulance with her mum, came through A&E and got admitted onto our emergency floor. She had a past medical history. She was 45, female, past history of Eisenmenger syndrome, Down syndrome, and a previous cardiac arrest in 2015. So really big history. Presenting complaint, she'd been unwell for 4 days at home and recently choked on a little bit of food. She came into hospital cyanosed, very blue lips, very blue limbs. Her SATs were 52% on air. She was very hypoxic. She was very septic. Her temperature was raised, her BP was low, raised CO2 and CRP, but her HB was 166. So I really was like, what's going on here? Why are we transfusing? There's got to be a reason for it. Next slide, please. So in the notes, the diagnosis was aspiration pneumonia. Obviously, from the choking episode, she got an infection there, but also iron deficiency anemia from the antiplatelet drug that she'd been taking, clopidogrel. So the treatment plan was IV antibiotics, fluids, oxygen, of course, and AIM HB for 200. Wow, okay. The plan was to transfuse 2 units of red blood cells with furosemide and have an iron infusion when the infection improved. So I'm just going to quickly tell you kind of the end result of what happened with this lady. She had 2 units of red cells transfused really slowly over 3 hours each with IV furosemide. And her HB had reached 180 after the 2 units from 166. And then a few days later, she had her iron infusion and they got that HB up to 194. And she recovered well and was discharged after 2 weeks. So, next slide, please. So, basically, what the consultant explained to me was this lady has Eisenmenger syndrome. She's had it from birth. It's basically a hole in the heart, what's known in the business. But this one involved all chambers of her heart, and this lady lived in kind of like a compensatory state to survive, and I don't think there was any treatment for her. So basically this is how she would normally live. So her congenital septal defect is where there's a hole, and it's where deoxygenated blood and oxygenated blood are leaking backwards and forwards, and it's what's known as a shunt. So obviously the blood is coming from the lungs oxygenated, but because there's a defect there, this full oxygen-rich blood is not being pumped to the rest of the body sufficiently. There's a lot of deoxygenated blood that's being pumped around. So of course she's that makes her hypoxic. And this leads to the overproduction in red cells. So looking back at her lab results and speaking to her mother as well, who knew a lot about her condition and her hemoglobin, the normal hemoglobin for her was 200, and it had been for a long time, and this is how she lives. And the consultant explained to me that it's almost as though the patient is constantly living at altitude. So obviously she presented to hospital with a drop in this hemoglobin, and it was very important to get her back up to her norm, which was 200. And I'd never seen anything like this. The BMSs had never seen this. So this was really important to communicate across the team, for everyone to understand what's going on here and why we're transfusing. It's very much out of the norm. And of course, the drop was due to the iron deficiency. So next slide, please. So it's highlighted the transfusion practitioner role in these cases. We really had to work outside the norms here, and there were lots of professionals involved in this lady's care. She was very, very poorly. So we needed to make sure everyone was on board to make sure this patient got her treatment as quickly as possible. So obviously going down to the clinical area was really important. Physically go down there, speak to people, not just a phone call, just go down there and speak to people. The consultant was brilliant. He really explained everything to me. And of course, I could explain to the clinical area of the anxieties of the BMS and the lab team, and make them aware that we've got a team up there who are very anxious too, and encourage good communication between them. So once I'd got the gist of everything down in the clinical area, off I went back up to the lab to reassure those guys. And once I'd explained everything to them, they were cool. Everything was great. Everyone understood the condition a bit more, and everyone relaxed, and it was fine. And everyone carried on with the treatment, issuing of the blood. I just encouraged them to document everything that was happening, all the treatment decisions and the rationale behind it. Try and document what you can. But I think I really wanted to go back to the clinical area, physically go down there and speak to the nurse. The nurse is the one who's frontline here, who's giving this treatment to this patient, and we're not working in the norms here, and it's a very complicated case. We don't really see this at all. And the lady had a very big history, so it's very scary for that frontline medical team. So I went and had a chat with the nurse. She was very busy, got a very big workload, obviously, an emergency floor. But it's so important for me to make sure that the nurse fully understood this condition, and that she was aware of the risk of fluid overload for this lady. Does she know how to look out for the signs and symptoms of TACO? Make her aware that it's okay to pause the transfusion if she's ever worried, and get that review. I told her where to find me if she needed me with any support doing the transfusion if she was worried, because what worried me a little bit as well was that the nurse had previously refused to do these transfusions for this lady as well. So there was obviously a lot of anxiety, and I really wanted to ease that for her and make her know that we were all on board and there to back her up. Also, I just flicked through and made sure that she got all her fluid balance charts there ready, encouraged extra observations and any change, communicate it with the team, and also have a good rapport with the family, and make her know that she can approach the consultant, approach the doctors, approach the lab. We're all there together. And if there'd been any change in the treatment plan, make sure she communicates that with the lab, because these guys are working behind the scenes. They need to know what's going on. And very importantly as well is that she's able to hand this information over to the next nurse who's going to be looking after this patient and make sure it is continuous through her stay. So it was an absolute success, and I think the TP role there, it's just great to get in there and really support everybody and bring everybody together. It's a rare case. Everyone was shocked, frightened. So I think it just shows the importance of our role, and how actively being present and running between the departments is just great. You're tangible, you're there for support, and this lady got what she needed, and it was a great success. Next slide, please. So just to quickly reflect back on everything, the staff here at St Richard's were presented with a very rare disease, never seen it before. My colleagues worked here for 20 years. She said she's never seen anything like this before. There was a reason behind it, and we had to be flexible and open to change and work outside of our norms. So important. We're a multi-professional team with each with our own anxieties and you know, our perceptions on things. So maintaining that positive link between the lab and the clinical area is so important, and having someone physically run between the departments just makes things a little bit easier, I think. Understanding the condition met the needs of that patient very, very quickly. Having that consultant rationale behind the treatment decisions was excellent. Luckily, that consultant had a brilliant expertise in this area. It could have been somebody else looking after this lady who may not have known much about this condition. He highlighted this in her past medical history, because taking it on face value, that lady came in with sepsis, and it was at risk of an issue with cognitive bias, big time really. She could have just been treated for her sepsis and sent home quite easily, but luckily people looked at her history, looked at the bigger picture, and she was treated correctly, and they saved her life basically. Yeah, basically, I think we all need to work together, be physically present. You know, I think a TP should be able to de-escalate conflicts of opinion, you know, and really collaborate, and get the treatment to the patient what she needs. And very importantly, have a really good communication with the family as well, because this lady was very poorly, and I think her mum advocated for her a lot in this case. So listening to family was very important as well. Next slide. Thank you very much for listening, and if that has generated any questions or any advice, then I'm all ears. Thank you very much.